Good morning, everyone. I am Prashant Agrawal, General Manager Marketing from Adley Oncology. And on the behalf of Adley Oncology, I welcome today's webinar on precision medicine in hematology from genetic insights to targeted therapy. I extended my gratitude to Dr. M.B. Agrawal. I welcome our chief guest, Dr. Siddharth Turkar, and the guest speaker, Dr. Nikhil Kumar. Once again, I welcome all the discussants and the participants. As you know, the Adley Oncology is one of the fastest growing company, and it is the one of the widest range. It has one of the widest range of anti-cancer drugs in manufacture of anti-cancer drugs in India. Our mission is to advance healthcare through innovation, quality, and the collaboration. I am happy to announce that recently the company got the in vivo approval for injections and its solid formulation. This is the testament for its quality and state of art manufacturing facilities. We are having rich portfolio in hemato-oncology, and very soon we are going to launch methotrexate oral solution. Patient first is our guiding principle, where we always try to provide NDDS formulation which is more effective and the patient friendly. We always look forward for the patient supports, patient education, and we believe in providing the cost-effective medicines. We do help needy patients through our patient assistance program, which are easy to process. Drug support reaches to the patients within 24 hours, and all the drug supports are will be in the discussion of doctors based on the affordability of the patients. Thank you very much, and I hand over the session to Dr. M.B. Agrawal. Over to you, sir.
Yeah. Thank you. Good morning to one and all. Today, our guest speaker is none other than Dr. Nikhil Kumar, now relocated to Kochi. He'll be lecturing to us on precision medicine in hematology, from genetic insights to targeted therapies. This webinar is brought to you by Mumbai Hematology Group, supported by Adley, managed by Perfect Square. I'm grateful to Mr. Ashutosh Shukla, Mr. Prashant Agarwal, and the team from Adley, Mr. Yash, Mr. Kalpesh, and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest, Dr. Siddharth Turkar from Mumbai, a guest speaker, Nikhil Kumar from Kochi, all our discussants who are themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning or afternoon or evening, depending on which part of the world you belong. Next weekend on Saturday, we have 2 lectures. The first one at 7 p.m. is by Dr. Umang Agrawal, an ID specialist from PD Hinduja Hospital, Mumbai. He will be telling us about the new kid on the block, which relates to newer antimicrobial agents in the Indian context. Very, very important to the hematologist and hemato-oncologist, medical oncologists. This will be followed by Dr. Samir Parekh's lecture from US, which will be at 8:15 p.m. Indian Standard Time. And he'll be telling us about updates from both ESCO and IMS in the field of hemato-oncology. Next Sunday, 12th October, in the morning, 11:30, we have Dr. Riya Balikar from Nagpur speaking to us about transforming treatment paradigms in chronic lymphocytic leukemia. Our discussions today, and we've got a galaxy of them. These names are put up over here alphabetically. There are probably a few more who have also shown their interest and have already joined us. And I'm grateful to all of them because they are the ones who are going to carry on with the Q&A session after the lecture. Just to introduce our guest speaker for the day, who does not require an introduction, in fact, Nikhil is a consultant hematologist. He was till yesterday in the Department of Hematology and BMT at the Fortis Memorial Research Institute, Gurugram, and has moved to Kochi this week. He serves as the clinical lead in the myeloma division. He obtained his MBBS from St. John's Medical College, Bangalore. This was followed by internal medicine at Guwahati Medical College, super specialization in hematology from AIMS Delhi. His clinical and research interests span plasma cell disorders, bone marrow transplantation, novel therapeutic strategies in hematological malignancies, and so on. As clinical lead of the myeloma division, he focuses on optimizing the treatment pathways, transplant outcomes, and patient-centered care in myeloma. He has authored peer-reviewed publications in both national and international journals and has contributed to advancing the understanding and management of hematological disorders through his academic work and clinical practice. And as I mentioned, he will be talking to us on precision medicine and hematology from genetic insights to targeted therapies. Before he does that, let me introduce our guest of the day. Now, chief guest of the day is Dr. Siddharth Turkar from Mumbai itself. Dr. Siddharth Vaman Turkar is a senior consultant in medical oncology at the prestigious Apollo Hospital in Navi Mumbai. He did his DM in medical oncology from the prestigious Tata Memorial Hospital way back in 2017. He's ESMO and EHA certified with over a decade of experience in managing both solid tumors and hematological malignancies, as well as immunotherapy, targeted therapies, cellular therapies, and palliative care. He has been recognized with multiple honors, and some of these include My Healthcare Excellence Award in 2024, Chikitsak Samman 2022 and 2024, Dainik Bhaskar Eminence Award 2023 for his contributions in the care of cancer patients. He has published and presented nationally and internationally, including at ESMO Asia, the European Hematology Association, and the Japanese Society of Hematology. We are privileged to have him today to inaugurate our webinar and give us some words of wisdom. Over to Siddharth.
Uh, Thanks for kind introduction. Good morning, everyone, respected colleagues, faculty, and most importantly, the young students and future specialists gathered here today. It gives me immense pride to be with you at the inauguration of this hematology webinar. Hematology is not just about red cells, white cells, and platelets. It is about life itself. The blood is the river that carries oxygen, immunity, and healing throughout our bodies. To dedicate yourself to hematology is to dedicate yourself to protecting that river and in doing so to transform countless lives. We are living in an extraordinary time. Just a decade ago, many blood cancers carried grim prognosis. Today, with targeted therapy, immunotherapy, and cellular therapies like CAR-T, we are curing diseases that were once considered to be incurable. Bone marrow transplants are no longer miracles of rarity. They are becoming standard lifeline. Every new discovery in this field is not just a line in textbook, but a lifeline for a patient waiting for hope. But the real reason I wish to inspire you today is this: hematology is still a young science in many ways. We have mapped the genome, but not yet mastered the secrets. We have powerful drugs, but resistance still challenges us. We have technologies, but access remains unequal. This means that the next breakthrough, the one that will define the next 20 years, will come from you. Each of you here has the power to change the trajectory of this field. Whether you choose the research, clinical care, or public health, remember that hematology gives you the rare chance to see the immediate fruit of your labor. A leukemic child going into remission, a young mother cured of lymphoma, a grandfather living years longer because of a targeted drug. Few specialties give such tangible rewards of science and service. So, as we begin this webinar, I invite you to dream boldly, learn rigorously, and question fearlessly. With that, I congratulate the organizer and declare this webinar inaugurated. May this platform ignite curiosity, collaboration, and compassion in all of you. Thank you.
Thank you, Siddharth. That was beautifully crafted speech. Thank you for sparing your time and inaugurating this webinar. It was so beautiful. I request you to forward it and like to put it up at the MHG website. It's very,
Thank you,
very.
sir. Thank you.
Thank you. And now, Nikhil, over to you.
Thank you, Dr. Siddharth, for those words of wisdom. Wonderfully put regarding how precision medicine has changed hematology, and what was not possible probably a decade back is common practice now. I'll just share my screen. Is my screen visible in full screen?
Yeah.
And yeah, perfect. So good morning, one and all. I thank MB Agarwal sir, Amit sir, and the Mumbai Hematology Group for giving me this opportunity to deliver this lecture. Before I start with the topic, my experience and collaboration with MHG has been memorable. Even before I started my DM training in AIMS, when I was trying to prepare for hematology, this was in the peak of COVID, early 2020s. My mentor back then, Dr. Jeena Bhattacharya from Guwahati Medical College, recommended MB Agarwal sir and his guidance in even preparing for that. And if I remember correctly, that was somewhere around that time when the MHG webinars started off in a big way, with Dr. MB Agarwal sir delivering the first talk on hematological aberrations in COVID. And from then on, to have consistently every Saturday and Sunday and other special webinar series for a period of 5 years is a big achievement in itself. For someone from Fortis who has been trying to organize webinars once a month, I really know how difficult it is to organize a webinar, get speakers, and get the program going. So doing it twice a week for 5 years is a phenomenal achievement. And to my colleagues and juniors, I always quote this: MHG webinars are the finest collection of webinars and the easiest way to stay updated in hematology. Across a span of years, it covers all the topics with renowned speakers from across the world. And we are really fortunate to be a part of this, both as speakers and panelists over the last 5 years. Moving on with my talk, precision medicine and hematology, from genetic insights to targeted therapies. We all know how genomics has evolved over the last decade and how targeted therapies are shaping the field of hematology. This would be the overview of my talk. I would go over and discuss the laboratory technologies, the advances in genomics, which has made targeted therapies possible in the first place. We should be thanking our molecular hematology and laboratory colleagues, because without them, we would not be having half the treatments that we have for our patients today. We are all familiar with disease-specific targeted therapies. I would not go over this in great detail, but like to brush upon the major advancements in the field and how targeted therapies are changing almost all branches of benign and malignant hematology. The future looks promising with more advances, treatments becoming cheaper, diagnostic tests becoming cheaper by the day. What are the limitations we face today, and how can we utilize these treatments keeping in mind the best interest of our patients? One size does not fit all. We all know this when we treat our patients. One patient may respond beautifully to a particular treatment, but the same treatment for the same diagnosis for a different patient may not provide the same results. This always keeps us thinking what should be done differently. And now We are discovering the answers one by one. We understand how each patient is different, how each disease has a myriad of genomic manifestations which are different, and how treatment should be tailor made for each patient, fully understanding that the genomic profile of the disease, the comorbidities of the patient, and the particular treatments has to be tailor made for each patient. What is precision medicine? This was a definition which was given by EHA in their position statement in 2021. Quite complicated. Concept or approach in preclinical, translational, or applied medicine that takes one or more defined molecules, cells, and interactions into account with the aim to improve diagnostic, prognostication, prevention, and treatment in hematological neoplasms. Basically means the role of precision medicine starts all the way from a preemptive or preventive strategy to optimal diagnosis, choosing the right treatment for the right patient, and also in monitoring these patients post treatment. So, tailoring medical treatment based on a patient's individual genetic and molecular factors is the key. And this has helped to reshape the diagnosis, risk stratification, treatment decision, and disease monitoring for our patients. Someone like MB Agarwal sir, who has been practicing for more than 3 decades, sir has literally lived this journey. We have come a long, long way from discovery of TKIs, imatinib being the first approved in early 2000s, to monoclonal antibodies, CAR Ts, and bispecifics. So over the last 3 decades, all the treatment modalities have literally had a transformational leap, and we have come a long, long way as far as treatment modalities are concerned. And this would definitely not be possible without advancement in genomics, advancement in molecular hematology, which has paved the way for us to identify the targets, thereby developing targeted therapy against this. So, genomics and advancement in these techniques has played a huge role in precision medicine. As we all know, malignancies are driven by distinct molecular alterations, leading to different subtypes and varying treatment responses. Now we know even diseases like myeloma, which were considered to be a single disease, is not so, and there are distinct subtypes in every disease, making it very important to understand the molecular alterations leading to the disease. Standardized protocols, which were the norm maybe a decade or two back, have been replaced by protocols which are tailor made to each patient. One size fits all approach neglects the individual variations not only in the disease biology but in the individual patients that we select for treatment also. Precision medicine is a branch which actually seeks to overcome this by aligning the treatment with unique genetic profile of each patient's disease. This slide provides a flowchart or a summary based approach where once patients come to us with a disease, starting from the initial test, be it NGS, RNA sequencing, whole exome sequencing, to identify the genetic pattern of the disease, to more advanced tests, epigenomic and proteomic based tests, which are probably more research based at this time point. We have identified biomarkers which play a crucial role in manifestations of the disease. And with advancement in technologies, we have been able to target many of them in the best interest of our patients. We are living in an era of targeted therapy, starting from imatinib in early 2000 to a whole lot of targeted therapies, including FLT3 inhibitors, IDH inhibitors, and off late in the last 5 to 7 years, CAR T cells, bispecifics, monoclonal antibodies. We have come a long way. But the real challenge is in identifying which patient would really benefit from the best treatment and how to tailor make these treatments for individual patient, fully understanding the cost implications and the risk guided treatment approach which are required. Choosing treatment has never been more difficult. With whole lot of options available, choosing the right treatment for the right patient becomes the key. Post-treatment monitoring strategies have evolved significantly over time. Even when we monitor patients for treatments post AML or ALL, we have moved a long way from a morphological remission to a MRD-based, multi-parameter flow cytometry-based treatment into the era of NGS MRD. Till very recently and even now, we monitor lymphoma patients post-treatment, end of treatment PET scan, and so on. ctDNA and other monitoring technologies have making a huge leeway in this field, with various studies showing molecular-based MRD monitoring can pick up relapses far earlier and with greater certainty in various types of lymphoma and other malignancies. We would want to discuss a few of these today. But before we go on to the clinical part, I would like to discuss the genomic tools which have made all this possible. Next generation sequencing is a revolutionary technology where high throughput sequencing, millions of strands of DNA and RNA can be sequenced in a very short period of time in a cost effective manner. And this has thrown up a lot of information regarding the genomic insights and the molecular pathogenesis behind each disease. Epigenomic and proteomic analysis, as we speak, are gaining ground, and we know how epigenomic modifications, changes in methylation, has proven to be causative in many diseases like AML and others. Liquid biopsy strategies, especially ctDNA, would very soon replace or rather complement imaging technologies in many fields like lymphoma. When it comes to genomics and NGS technologies, starting from targeted panels, which we use very commonly, like the myeloid NGS panels, to whole exome sequencing, where only the exome is sequenced, and for diseases like inherited bone marrow failure syndromes or rare genetic defect, to a widespread whole genome sequencing, which can identify alterations in the non-coding regions also. All these technologies are widely available to us. Again, the challenge is to identify which test to order for which patient. Transcriptomics, just like the DNA sequencing technologies, we have realized that sequencing RNA is equally important as far as identifying fusions are concerned, be it BCR-ABL, be it NUP98 fusions. Transcriptomics also play a very important role in our day-to-day diagnostic practice. And for all the young hematologists here, we always should order for an NGS test for myeloid malignancies with both DNA and RNA fusions covered. Otherwise, very often we may miss important fusions if only the DNA is tested by an NGS. Epigenomics like methylation sequencing, chip sequencing, ATAC sequence can identify methylation patterns. We know diseases like AML where hypermethylation, especially in the IDH mutated AML, is important in the pathogenesis. So these can be picked up via epigenomic based testing. The utility of NGS and sequencing is not just limited to diagnosing malignancies, but it has also made leeways into better testing for infections. My infectious disease colleagues tell us that metagenomics and testing for specific infectious disease RNA profiling can have a quick turnaround time and early identification of not only the pathogens, but also the mutation mechanisms and the resistance mechanisms. So across diseases, including the infectious disease, genomics have a big role to play, not only in diagnosis, but also in monitoring these patients. The sequencing technologies have come up in a big way. It has evolved from the early Sanger sequencing all the way to high throughput NGS, and we are treading along a line where many technologies like single cell sequencing and spatial transcriptomics are coming into routine practice. So over the last 4 to 5 decades, we have come a long way in developing these sequencing technologies. They have become more and more specialized, faster, easier to perform, and the cost has come down significantly. So as we discussed, next generation sequencing is a high throughput sequencing technology detecting a wide range of genomic alterations, and this plays an important role in hematological malignancies, not only in the diagnosis and risk stratification, but also in selecting the right treatment and MRD monitoring. And these tests are available to us at a much rapid turnaround time, and the cost has come down significantly over time. I remember around 6 to 7 years back when I was a DM resident in AIMS, ordering NGS was considered a luxury. individual tests would cost anywhere between 20 to 25,000 rupees, and for very select patients, we would order NGS. We would, for vast majority of the patients, PCR-based testing for detecting FLT3 or NPM1 or PCR panels were broadly employed. But now we have come to a stage where the cost has come down at least by 50% or more, and almost all the practitioners, be it hematologists or oncologists, order an upfront NGS in diseases like AML or MDS. And even in all the international classifications, be it the diagnosis and risk stratification, it is incomplete without a genetic sequencing. So this has come up in the last 1 decade, and the way the field is expanding and the speed at which things are progressing is actually mind-boggling. Higher cost is still a concern, though it is coming down by the day. But what is more critical to know is the huge amount of information that it generates. So playing a role for bioinformatics, standardizing these tests is a challenge which our laboratory colleagues face on a day-to-day basis. And very often we are thrown up with variants of uncertain significance and many mutations, which makes it confusing and we really don't know what to do with them. Sequencing in practice from the targeted approaches like a myeloid panel or a lymphoid panel, which we commonly order, to whole exome sequencing, which covers only the exome or coding region of the genome, which accounts for only around 1 to 2% of the genome. Whole exome sequencing when it is a rare genetic disorder or an inherited bone marrow failure syndrome where the known we need to look for mutations beyond the known panels, starting with our excellent whole genome sequencing technique, which probably is an extensive test covering the whole genome, 3 million base pairs plus, which can look at rare findings or rare mutations even in the non-coding region. All these tests are available to us easily, with many labs offering them at good prices. But the question always is which patient deserves which test. Clinical acumen and judgment plays a big role in deciding this. From the whole genome project in the early 2000s to rapid NGS technologies in 2022-23, the cost has significantly come down. In an Indian setting, probably the cost is even cheaper than this. We all know these tests, which used to be significantly costlier a decade back, are easily available to us, and almost all patients are able to get these tests done at baseline. We always counsel our patients to get all the tests done so that we know the disease, the correct risk stratification, so that we can offer the best possible treatment for the patient. Whole exome sequencing focuses on the protein coding regions, which constitute only around 1% of the genome. More cost effective, and in majority of the conditions, this would suffice. This can also help to identify germline predisposition syndromes like Leaf-Romany, GATA2, etc. However, as compared to targeted panels, the sequencing depth is lower. So if we are looking for a specific mutation and we want to pick up mutations at a low VAF, probably targeting panels would be the way to go. RNA sequencing or transcriptomics is equally important to pick up fusions. Very often when we do next generation sequencing tests, which looks at only the DNA sequencing, we are bound to miss fusions like BCR-ABL and Nuc98, which is very important to identify because they have important therapeutic as well as prognostic significance. However, RNA is quite unstable compared to DNA, and this test should be performed immediately after the sample is drawn. So this is a drawback, especially in areas where the test is not readily available and the sample has to be transported over large distances. So sample quantity and handling becomes very important in RNA sequencing. Just to touch upon epigenomics and proteomics, epigenomics studies the gene regulation which do not alter the DNA sequence. DNA methylation is the most important example, which plays a central role in AML and MDS pathogenesis. Technologies like methylation arrays, bisulfite sequencing define epigenetic signatures, and proteomics is the study of protein expression, structure, and modifications, revealing cancer biology, FLT3 phosphorylation in AML. Integrated test, which includes genome, epigenomic, and proteomic approaches, plus tools like liquid biopsy and test at a deeper sequencing depth for MRD, play an important role in enhancing diagnosis, prognosis, and precision treatment for our patients. Just to summarize what we discussed till now, these tests can be performed both on body fluids as well as tissues. An integrated approach would be to select what exactly we are looking for and what is the best test to identify this, including genomics, epigenomics, transcriptomics, proteomics, and a combination of this. These tests throw up huge amount of data, and processing and storing this data is a challenge in itself, which is where artificial intelligence and machine learning platforms come into the picture for analyzing this large data, churning out newer biomarkers, and this plays an important role in research, diagnosis, and therapeutics. ctDNA is something which has gained a lot of traction in the last couple of years. And the reason for this is it's a non-invasive test where circulating tumor DNA can be easily picked up from blood tests. It is important to distinguish circulating tumor DNA from other cell-free DNA from non-tumor cells as well as tumor microenvironmental cells, and this requires a lot of expertise. There are a lot of methods to look at ctDNA. What we used to follow at Fortis was an NGS and low pass based technology, and we have been trying to integrate ctDNA into our routine clinical practice to try and see the concordance with PET and to see whether we can identify relapses earlier. It also plays an important role in post-CAR-T monitoring. Utilities of ctDNA goes well beyond monitoring in specific situations where a biopsy may be very difficult. Hodgkin's patients who has undergone 6 cycles of ABVD, we do a PET and see a lymph node in the para-aortic region, dual 4-5, very difficult to biopsy. In such situations also, ctDNA can come to a rescue. If we know the baseline pattern, we can always compare and assess the ctDNA to see or guide us whether we are truly looking at a refractory disease or what is a concordance with PET. It also plays an important role in tumor burden assessment. In situations like a post-CAR-T monitoring, we have been trying to do ctDNA on a monthly basis, basically to understand the tumor kinetics and see how well the disease has responded. This can be a powerful tool for MRD monitoring. Non-invasive test can be easily done on an outpatient basis, and one standardized MRD monitoring can be done in lymphoma patients with ctDNA technology. This was some data which was presented at the recent ASCO meeting regarding prospective validation of end of treatment ctDNA in DLBCL patients. Samples were assessed at baseline as well as post-treatment. More than 50 centers from Netherlands and Belgium participated in this study. Newly diagnosed DLBCL patients who received first-line treatment either with R-CHOP or dose-adjusted EPOCH-R. And as you can see, end of treatment ctDNA is strongly prognostic for progression-free survival as well as overall survival. The curves separate out beautifully, and if we are MRD positive, we are more likely to relapse much earlier than considering patients who are MRD negative. But what was more interesting to note is that ctDNA was independently prognostic for PFS, meaning to say, even in patients who are end of treatment PET negative, if they were ctDNA positive, they were more likely to relapse. As you can see, in patients who had complete metabolic response by PET scan, and this is our treatment goal according to current standard guidelines to achieve a CMR by PET post 6 cycles of treatment. These patients who are MRD positive, the 3-year PFS was only 36% versus 89% for patients who are MRD negative. Meaning to say, this may be a more sensitive marker for picking up relapses, and this can complement PET scan in picking up patients who might benefit from consolidation, maintenance, or further treatments. Even if PET scan is negative at 6 cycles, if the ctDNA MRD is positive, the relapse risk is much higher. This was a prospective study which confirmed that ctDNA MRD after curative first line treatment is highly prognostic and provides an independent evidence of residual disease which goes beyond PET scan. And this should be integrated into a standard response for first line DLBCL patients. Not only for DLBCL, in almost all categories of lymphoma, ctDNA has been tried and tested. Going back to the last ASH, this was an oral abstract which was presented, which looked at the utility of ctDNA in early stage and advanced stage Hodgkin's lymphoma. It was seen that in early stage patients, cycle 3 day 1 ctDNA and advanced stage patients, cycle 5 day 1 had important prognostic implications. Patients who are ctDNA positive had a very high likelihood of relapse. How can we integrate ctDNA into our routine clinical practice, and MRD monitoring is something which should be studied more exclusively. And we are trying to look at this in a prospective fashion at Fortis. I will not discuss about details of NGS MRD monitoring. We all know in ALL as well as myeloma, NGS MRD is standard place, be it by clonosec or NGS MRD in myeloma. There is good data to show that treatment modifications can be based on this. In the field of multiple myeloma, almost all the recent trials take into account NGS MRD, and time limited treatments and treatment de-escalation or escalation based on MRD has been studied extensively. I'll not go into the details of that, but something which I would like to bring out, which we are routinely doing in Fortis since the last 1.5 years, is the concept of NGS MRD in AML by error corrected NGS. Error corrected essentially means in NGS based MRD testing, very often during the PCR amplification and processing, there can be sequencing errors, and there are specific methods to look for corrections in this. And error corrected NGS can be a very powerful MRD monitoring tool. This was a small study which looked at NGS MRD in AML patients. Till very recently, we used to rely only on PCR MRDs based on either FLT3 or NPM1 for assessing prognosis and important decisions like eligibility for transplant for these patients. With vast majority of the mutations, including the so-called DTA mutations, DNMT3A, TET2, and ASXL1, we still do not completely understand the prognostic value of all these mutations as markers as far as MRD is concerned. Can NRAS, KRs, IDH can they be treated as MRD markers? And if they are positive post treatment, pre or post transplant, what is the prognostic significance? This study tried to look at that. The variant allele frequency of the markers was looked both at diagnosis as well as CR1. I'm sorry for the poor quality of this slide, but if you can appreciate the red line in each box, that converts to a VAF of 0.1%, and any mutation which was seen more than 0.1 was considered to be significant in this. And as you can see, when these patients were followed up over time, the curves separate out nicely. Patients who are MRD negative, the blue curve below, patients who are DTA positive, these are very often not given enough importance. DNMT, TET2, and AXXL1, many of them are considered to be CHIP markers. But post treatment, even if these markers persist, the risk of relapse was higher. And if any other marker, be it NRAS, KRAS, IDH, persisted post treatment, the relapse risk was significantly higher than the patients who had an NGS MRD negative. So this study went on to conclude that persistence of any mutation, including the DTA, was associated with unfavorable prognosis, and the number of detectable mutations in CR1 was highly predictive of relapse and survival. What was more interesting to note is that even those patients who underwent an allo transplant, this did not abrogate the poorer prognosis associated with NGS MRD positivity. We have been monitoring all our patients with NGS MRD pre and post transplant at Fortis, and we have seen even post transplant 1.5 years later, patients who have an NGS MRD positivity, many of them do eventually relapse. a lot of questions remain unanswered. What are the time points where the MRD should be monitored? What is the cutoff? What is the cutoff that should be looked at? And most importantly, if the patients are MRD positive, what are the therapeutic interventions that are possible to reduce the risk of relapse? But this and many more data sets have shown that NGS MRD can be a powerful tool to guide prognosis and treatment decisions in patients post-treatment and post-allogenic stem cell transplant. Moving on to disease-specific targeted therapies, we are all familiar with all treatments, starting from rituximab, which was initially approved for low-grade BNHL as a single treatment in 1997, to the iconic trial which compared RCHOP versus CHOP and showed a significant PFS benefit with rituximab, to imatinib or Glivec approval via IRIS trial. We have come a long way as far as targeted treatments are concerned. And in the last decade or two, the number of targeted therapies which have been approved are significantly more than what was there maybe in the past 3 to 4 decades. And this can be attributed to the rapid technological advances that we have made in genomic sequencing and identifying novel targets which can be targeted as far as individual diseases are concerned. Moving on to targeted treatments, to CAR Ts, bispecifics, monoclonal antibodies, we have a whole lot of treatments which we have. This table by no means is exclusive, and this shows us a glimpse of treatments which are available for almost all the diseases. Any given hematological disorder, as of now, we have targeted treatments available. And this is not unique to hematological malignancies alone. This is true even for benign hematological disorder. CML is probably the best example to show how targeted treatments can significantly revolutionize a field. Moving on from busulfan hydroxyurea, interferon and low-dose cytarabine was probably the standard of care in the early 90s. The IRIS trial changed everything, which led to approval of imatinib as the standard of care in CML. And after this, we have both second generation and third generation TKIs, including ones for resistant disease. This was a landmark publication in NEGM, which compared imatinib with interferon and low-dose cytarabine, which was a standard treatment for CML in that era. A clear, significant improvement at 12 and 18 months. The major cytogenetic response was significantly higher in patients who received imatinib as compared to the combination treatment. The long-term outcomes of this trial were published in 2017 at a median follow-up of around 11 years. More than 80% overall survival and complete cytogenetic response. Phenomenal achievement. And this has literally changed the field of CML, and this paved the way for many more targeted treatments in other fields of hematology. A whole lot of treatment targets are available to us, and this has been extensively studied in AML. So much of research going on into newer treatments and new identification of newer targets. And the timeline for FDA approval also reflects this. Starting from midostaurin in 2017, enacidinib, other FLT3 inhibitors like gilteritinib, IDH1 inhibitors, to the recent approval for revumenib for relapse refractory KMT2A mutated AML. We have a whole lot of targeted treatments which are available, both for upfront as well as relapsed use in AML. This was the ratified trial which looked at addition of midostaurin to a standard chemotherapy regimen of 7+3 followed by high-dose cytarabine consolidation in newly diagnosed AML patients. As you can see, the median overall survival benefit with midostaurin and the PFS benefit probability of survival was 74.7 months with midostaurin as compared to 25.6 months with placebo. And this benefit was reflected in ITD, high variant allele frequency, low variant allele frequency, as well as some patients with TKD mutation, which basically reflects on the multikinase inhibitory action of midostaurin in these patients. Moving on to acute lymphoblastic leukemia. A decade back, relapsed ALL was a nightmare to treat. Intensive toxic treatments And I still remember the number of patients who would achieve a remission and go on to a transplant once their ALL relapses was minimal. This has changed with molecules like inotuzumab and blinatumomab, where if patients relapse and they are CD22 positive, almost all of them, we are able to bridge them to a transplant thanks to these wonder drugs like inotuzumab and blinatumomab. Things have not caught up so well with TALL. This is still an unmet need. Though nelarabine is an approved treatment for relapsed TALL, there is still a dearth of novel molecules and CAR T cell therapies as well as TALL is concerned. We have made significant headways in treating relapsed BALL with both BiTE therapies, antibody drug conjugates, and the recent CAR T cell therapies, significantly improving survival for relapsed patients. Just like any other disease, now these medications are coming into upfront treatment. Upfront blinatumomab has shown significant PFS benefit, especially for adult patients, where around 40% of the patients tend to relapse within the first 3 to 5 years. So more and more treatments are becoming genomic based, and upfront use of these agents, including blinatumomab, has made significant PFS benefits for patients with acute lymphoblastic leukemia. Once patients relapse, especially adult patients, the prognosis is poor. These two drugs have changed the treatment paradigm for relapsed ALL significantly. Our strategy for relapsed BALL to look at CD22, and if patients are CD22 positive, we go for mini hyper CVD with inotuzumab as a bridge to allogenic transplant. In patients who have a low level of MRD positivity, blinatumomab can be a great strategy. And these drugs have also proven to be highly effective and comparatively less toxic with a favorable safety profile, even in elderly patients who are not able to tolerate other treatments. And both these medications have shown significant PFS benefit. And in real life clinical practice, it is very, very effective to use both inotuzumab and blinatumomab as a bridge to transplant. In elderly patients, especially Ph positive ALL, combination of ponatinib with blinatumomab has been proven to be a very effective chemo-free regimen. Blinatumomab consolidation upfront has shown to have significant PFS benefit even if the patients achieve MRD negative with the standard chemotherapy. Going on to say that in a decade's time, probably upfront treatment with blinatumomab and other BiTE therapies would be the way to go. 2017 was an iconic year. The first CAR T cell was approved for heavily pretreated ALL patients, and we all know how the field has evolved from there. With having very less options, if patients have refractory disease, many often, like Dr. Siddharth mentioned, there were no treatment options and these patients were referred for palliation. CAR T has changed this significantly compared to the standard of care, as you can see on the left. Significant improvement in the median overall survival in patients who could get onto our CAR T, and many of them have gone on to become long-term survivors. The utility of targeted treatments and time-limited therapeutic strategies is exemplified best in hematology by advances in CLL. Moving on from conventional chemotherapy regimens like FCR and BR, the entire field has probably switched onto targeted treatments like BTK inhibitors, BCL2 antagonists, and anti-CD20 monoclonal antibodies like obinutuzumab. I'll not go over this slide in detail, but the number of trials which are looking at exclusive targeted chemo-free regimens and many of them time-limited strategies, including doublets and triplet treatments in CLL is phenomenal. What is important to note is the PFS. More than 80 to 90% PFS in many of these patients. Phenomenal achievement considering these are easy to administer. Many of them are oral medications which can be continued on an outpatient basis. Precision medicine and targeted treatments have literally changed the treatment landscape in CLL, with patients having multiple treatment options. If patients have received upfront BTK inhibitors and they relapse later, a BCL2 inhibitor like venetoclax with CD20 monoclonal antibody obinutuzumab can be a great combination. If patients have received both these treatments, BCL2 inhibitor and CD20 monoclonal antibody before, BTK inhibitor based treatment can be given. And in patients who have failed all these treatments, CAR T cell can be a very promising option even for CLL patients. Moving on to lymphoma, the number of approved treatments, including CAR T cells, as well as bispecifics like glofitamab, epcoritamab, has been very encouraging for lymphoma patients. Refractory lymphoma literally used to be a death sentence where nothing used to work in chemorefractory patients. CAR T has provided a ray of hope in these patients, and even for our experience in the Indian CAR T setting, refractory patients, a lot of options like CAR T and glofitamab are available. Just like the ALL or the CLL space, these treatments have been tried in upfront high risk patients, and we are really excited to wait for the results of these trials to see how these patients fare with treatments. Lymphoma diagnosis to treatment has undergone a paradigm shift in the last decade, where lymphoma diagnosis now not only relies on an immunohistochemistry and the so-called Hans algorithm to classify patients into GCB and ABC type. We now know that the disease is much more complex than that, and there are many other genetic subgroups, including dark zone signatures and other subgroups of lymphoma, where the treatment response can be very, very different. So, identifying different genetic subgroups and giving tailor made treatments is the way to go forward for these patients. As far as relapse lymphoma is concerned, we all know with the traditional R-CHOP, almost 30 to 40% patients will eventually relapse. For patients who relapse within the first 1 year, CAR T cell is the way to go. And for patients who relapse post 1 year, getting them into a remission followed by an autologous transplant is the best treatment. If we are not able to get patients into a CR, again, these patients should be considered for an early CAR T cell treatment. Switching gears to multiple myeloma, probably no other disease in hematology has had so many drug approvals in the last 1 decade like multiple myeloma. Compared to the 1980s and 90s, there has been a significant improvement in the overall survival, where patients' overall survival has jumped from 2 to 3 years to more than a decade for most patients with standard risk myeloma. This phenomenal improvement in overall survival has only been possible because of the novel therapeutics that have been approved in the myeloma field. Immunotherapy is a success story in multiple myeloma, with even relapsed and multiply treated patients, bispecifics and CAR-Ts. The response rate is almost double of any other standard treatment, including daratumumab. Triplet regimens became a standard, and this was the norm till around a few years back. Now, almost all of us know if patients are affordable, almost be the patient young, old, fit, unfit. A CD38 monoclonal antibody based regimen is the best possible upfront treatment that we can offer for these patients. Trials like Cassiopeia, Perseus, and Cepheus trial have shown significant PFS benefit in these patients. The follow-up data of Perseus trial was presented at this year's IMS. Very exciting data. In patients who received DARA-VRD induction followed by consolidation and DARA-LEN maintenance, the projected PFS was more than 10 to 15 years. And this is significant achievement in a disease where the overall survival till around a decade back was less than 10 years. We have so many treatment options, not only for newly diagnosed, but also for relapse refractory and multiply pretreated multiple myeloma patients. And this has been possible due to various immunotherapy options which we have at our disposal. Starting from CAR T cell therapy like ID-cell and cilta-cell to antibody drug conjugates and bispecific antibodies which target multiple antigens like BCMA, GPRC5D, FCHR5, and SLAM-F7. A whole lot of treatment options are available to us. Again, the important trick is to understand which treatment for which patient, and the entire game in myeloma is to really sequence treatments in the most effective manner so that patients can benefit from them. I'll not go over the results of trial in detail, but for patients who have received 3 to 4 prior lines of therapy, teclistamab was a game changer with more than 60% overall response rates. Both ID-cell and cilta-cel have significantly improved our armamentarium. This was early results from the KARMA trial, relapsed refractory myeloma patients with more than 4 prior lines of therapy. Overall response rates of 70 to 80%, and the 5-year follow-up data showed a median PFS of 10.8 months with an improved overall survival of 28.3 months, which basically show we still have a long way to go. This data of cilta-cel, which was presented at the recent meeting, the long-term 5-year data of cilta-cel showed that 1/3 of the patients are disease-free and treatment-free after a single infusion of cilta-cel. So for the first time, probably in the history of plasma cell disorders and multiple myeloma, we are talking about possibility of a cure. And this is possible because of advances in immunotherapy and monoclonal antibodies for this disease. Majestic 5 results were published where high-risk patients were given upfront bispecifics, and 100% patients achieved an MRD negativity at 10 to the power minus 6 after 6 months of treatment, showing that early and aggressive treatment probably be the way to look for an early cure in multiple myeloma patients. And all this is possible because of precision medicine and advances in immunotherapy. While we discuss about this mostly in the malignant hematology field, it is important to remember that significant advances have been made even in the field of benign hematology. Betabeclugine automycel gene therapy was approved for beta thalassemia transfusion dependent patients a couple of years back. Patients who received gene therapy had significant transfusion independence. In patients who are less than 12 years old, almost all the patients achieved transfusion independence with gene therapy. Even in the field of hemophilia, we have approvals both for hemophilia A and hemophilia B. All these diseases, be it thalassemia or hemophilia, were considered as incurable diseases, which requires lifelong factor administration or lifelong blood transfusions. Gene therapy can be a game changer in these patients and offer the possibility of a cure for them. This is still not in widespread use because of the exorbitant costs, but I'm sure with advances in technology, the cost would come down, and one day definitely these treatments we would be able to offer our patients with the curative intent. CRISPR-based editing technologies have also gained a lot of traction, and a lot of work is going on in this field, both sickle cell as well as thalassemia. In sickle cell, CRISPR-Cas9 technology has been able to successively knock out BCL11A, thereby removing the inhibition on production of HbF, leading to increased levels of HbF and reduction in the disease severity in patients. These are all early days, but I'm sure with these technologies becoming more and more precise and cost effective, these treatments would be available to our patients in the near future. Any talk on precision medicine and hematology is incomplete without talking about the phenomenal influence of artificial intelligence in this field. With the sequencing technologies and the amount of data which is generated, it is humanly impossible to identify patterns and look at this data to classify them and look at novel markers. This is when artificial intelligence comes into play, where machine learning algorithms are able to process huge amount of data and identify patterns in them in such a way, be it pathology, be it radiology, artificial intelligence technologies can identify patterns much earlier from pathology and radiology perspective. AI has come into almost all fields of hematology, be it our routine use in our day-to-day clinic, be it looking at novel markers and identifying disease pathways. The average time for discovering a drug was 10 to 15 years, and billions of dollars would be spent on discovering these molecules. This has significantly hastened with artificial intelligence technologies, which are able to screen thousands and millions of drugs with advanced computational pathways leading to novel biomarker discovery, translating to newer drug discovery. AI-based technologies and algorithms are able to predict disease outcomes because they are able to screen patterns of disease in thousands and millions of patients, which would be humanly impossible. A very interesting concept is the concept of digital twins, where the novel treatment or technology can be tried out on a digital twin. Every patient can have a digital twin, and whatever treatment we have to actually give the patient to see whether works. A digital twin is a technology which helps, AI based technology which helps to see which treatment can work for which particular patient. These are early days, but widespread adoption of artificial intelligence in hematology and medicine in general is going to revolutionize the field in a big way. Role starting from storing the clinical information, assessing the specimen, running the right tests on that, generating and making sense of the huge amount of data which these tests generate, and also making prediction models, which helps not only in diagnostic part but also in understanding which patient is going to do well and which patient is not going to do well. Artificial intelligence has a role to play from the beginning to end of each treatment, be it novel drug discovery, which is rapidly hastened, or building new prognostic models which are better than the ones we currently have, or in the field of personalized medicine. This is a very important tool that is going to come into picture. A lot of work is going on clinical trials focused on genomic profile. Many of us are aware in the field of myeloma, almost all the trials are looking at next generation sequencing based endpoints and treatment modifications based on that. We are all aware of the myelomash trial, where an upfront next generation sequencing and identification of the molecular and genetic type of disease is done beforehand so that patients are offered genomic inspired treatment. This trial is occurring in the US, and many trials, be it myeloma, lymphoma, myeloid malignancies, a genomic profile inspired clinical trials would give us the answer regarding what is the right treatment for this right genomic profile of the patient. Personalized immunotherapy is familiar to all of us, be it CAR T, be it bispecifics. We have now learned how to harness the immune system to fight against the disease, and what are the drugs, be it a one-time CAR T infusion or be it bispecific antibodies, which target particular antigens on the disease, and through our CD3 T cells, they are able to neutralize this. Personalized immunotherapy has become a reality today. A word about single cell sequencing. All the sequencing technologies that we have or what we discussed are bulk sequencing, which helps us to identify genetic pattern of the disease as a whole, but this ignores the genomic heterogeneity in a disease. In a particular disease or tissue, there may be some cells or a few clones which are resistant to the treatment we are giving. Bulk sequencing fails to identify them. This is where single cell sequencing comes into the picture, where at a cellular level, we are able to understand the genetic profile of the disease. This can help in understanding the disease patterns better and also identify subclones of the disease which may be resistant to treatment. Even single cell sequencing does not identify the cell and its relation to the surrounding tissue. Spatial transcriptomics is a technology which identifies the role of cells and the position of the cells with respect to the surrounding tissues to understand how cells interact with each other. This becomes very important in diseases like myeloma and lymphoma, where the tumor microenvironment plays a huge role. While all these are research technologies at present, the speed at which the field is evolving, very sure we'll have these technologies for clinical use in less than a decade. Discovering new drugs is a costly affair. Artificial intelligence and novel pathways can help us to repurpose the drug, which basically means drugs which are already known and approved for some indication can be used for a different indication. A classical example of this is probably thalidomide, which was initially discovered as a sedative, went on to be used for morning sickness with disastrous complications like phocomelia, and finally found its right place in the treatment of multiple myeloma. And this went on as a game changer to discover new drugs like IMiDs, which have revolutionized the field of myeloma. So drug repurposing is very important, and this is easily possible right now with artificial intelligence technologies. The challenges remain high cost of genomic testing, still unaffordable for the majority, though with every day the cost is significantly coming down. The same holds good for targeted therapies. Very interesting to discuss about CAR T cells, bispecifics, daratumumab, and so on. But the reality is, for the vast majority of our patients, these treatments still remain unaffordable. These treatments are going to become cheaper with time, and probably we require indigenous treatments and research to get correct drugs for our patients. Access disparities remain a concern, and with tests and labs blooming everywhere, standardization is going to be a challenge. Our entire treatment follow up is based on the laboratory backup. So, to have a very good hematology, hematopathology, and molecular hematology backup is very, very important for our practice. The sequencing, next generation sequencing, whole exome sequencing throws up a whole lot of data. How do we integrate that and use it in our routine clinical practice is something which we have not yet mastered. And this is something which is a big challenge. With so much of technological advancements, we also require the right infrastructure and workforce to support precision medicine. Thus, to conclude, genomic discoveries have revolutionized hematology, enabling precise diagnosis, prognostication, and treatment. Targeted therapies, immunotherapies are redefining treatment paradigms, and multiomics, AI, real world evidence, these are all being integrated, driving personalized care and clinical trials which are looking at best interest of our patients. Gene therapy and genomic editing technologies like CRISPR have already moved from bench to bedside, and this is going to be available for widespread use hopefully in the near future. The future lies in combinational strategies, understanding how to use the precision guided sequencing to the best interest of our patients so that we can improve the survival and quality of life for our patients. I stop here and thank you all for the patient listening, and I'm happy to take questions.
Thank you, Nikhil. Beautiful talk. I had tens of questions in the beginning, but I'm not left with any question. You have answered everything. If there were gray areas, you have made them black and white. Thank you so much for this great talk. And I'm sure that those who are present here and those who have been listening from any part of the world, they all have benefited. You have thrown light on so many aspects that a person can probably live with it for the next 10 years, thinking, scratching his brain, how to apply all this. And yes, it's changed our practice. It has changed our way of thinking. Thank you so much for doing this. So now questions from friends present over here, as well as those who want to write it in the chat box. The first question that has come up in the chat box: it is not feasible to biopsy CNS tumors like DIPG and optic gliomas in pediatrics. Such tumors do not metastasize outside the CNS. Can CSF be used for testing cell-free circulating tumor DNA or RNA?
That's a great question. I'm not an oncologist, so I'm not aware of the treatment paradigms for solid organ tumors, but I can provide a very similar analogy from the hematology space. So, yes, in lymphomas, there are a lot of studies which are looking at circulating tumor DNA in the CSF. A very interesting study which was presented at the recent meeting looked at circulating tumor DNA at baseline in all DLBCL patients. And it showed that even patients who were CSF cytopath and flow cytometry negative, if there was circulating tumor DNA in the CSF at baseline, they were more likely to have a CNS relapse going forward. Very interesting data, which actually makes us redefine and rethink our diagnostic strategies. Because we all know DLBCL patients, once they have a CNS relapse, the outcomes are dismal. And no treatment, be it intrathecal methotrexate or high dose methotrexate, nothing has conclusively shown to be beneficial in preventing CNS relapses. So, if we could have better prognostic markers than CNS IPI, we can have more sensitive markers like ctDNA, which can probably tell us the likelihood of a CNS relapse. We may treat these patients differently. And one more case that we had recently, we had a patient who was WT1 mutated AML. Patient was treated, underwent transplant. 1 year post transplant, patient had an isolated CNS relapse. And at that time, we were actually looking at ctDNA as an exploratory tool in AML. We looked at ctDNA and the same WT1 mutation which could detect from the CSF. So I think, yes, there are ways and means by which we can look at ctDNA in the CSF, and this could probably predict who is going to have a more likelihood of CNS disease. And like Dr. Ali rightly pointed out, in difficult to biopsy tumors, this could be a surrogate to see or assess the disease activity.
Thank you. You touched towards the end of your talk that a lot of molecular hematopathology labs are mushrooming, and there will be more and more. The cost cutting is going on, the tax are getting reduced. Every evening, there are guys sitting in front of you telling what is better in their lab. Standardization is something which, sitting in our clinics, we cannot assess. As a society or as a group of hematologists, what can we do to really make out? Or, we used to talk about quality control in the days of our routine test also, whether it was anemia, coagulation, thrombophilia profile, everywhere, quality control, exchange of samples, and people used to accept these as a part of improvement of their labs. Uh, what can ISH, VT, or anybody do to take care of this aspect of these molecular labs?
Absolutely, sir. Like you rightly pointed out, this is a very big concern because it's a practical challenge for us sitting in the clinic. As clinicians, we are never able to judge which lab is good or which lab is bad. And the other problem that crops up is many patients very often come to us with a report from an XYZ lab. And these are very costly investigations. We cannot always ask the patient to repeat these tests again because we want to be done in house. So, quality control, I think, is very important. And I think the way forward would be to basically have molecular consortiums, just like we have IQUAS and we have Euroflow guidelines for next generation flow, which has more or less standardized the flow guidelines across Europe and United States. We definitely need such consortiums, and we require quality control and IQUAS between labs so that wherever we send our sample, the reports are reliable. Because not all institutions or hospitals, at least as of now, have an in-house molecular facility. And many of these samples, especially the RNA sequencing, which is RNA plus DNA, RNA is very, very prone to lysis. So by the time we transport the samples, it is gone. So ideal scenario would be to have an in-house facility which we can trust. But I think IQUAS with already recognized international labs should be the way to go.
Absolutely. I mean, for each institutional hematologist, there are probably 50 community-based hematologists and medical.
Absolutely, absolutely. And
And
community-based hematologists actually do the vast majority of hematology practice. Rightly so. In tier 2 and tier 3 cities, uh, our hematology colleagues are doing phenomenal work. Free transplants, almost all diseases treated with the best possible drugs. And many states are offering a lot of support also. So states like Rajasthan, MP, there are many places they are giving all these treatments that we mentioned at significant subsidized cost or free. So I think decentralization of practice is the way to go. And to have that, every place, at least every district or a state should have a few reliable labs, which is very important for our practice.
quite rightly pointed out that these tests very difficult to repeat them because of the cost involved. Sometimes you know that this lab that has produced the result is not trustworthy, but you cannot even speak about it. And same thing like bone marrow.
Absolutely, sir.
Somebody has done a bone marrow from the quality of performing the procedure right up to the reporting. Whole thing is not trustworthy, but it has been done on the patient because of the pain and the cost involved is not willing to undergo the test again. Same thing happens with the molecular hematopathology now, left and right.
Absolutely.
Yeah, please, questions. Everybody was spellbound by your lecture. I think you answered everything. At least you have answered everything that I had written down on my piece of paper. I'm not left with anything to ask you. Yeah. So, okay, then if there are no questions, Nikhil, thank you so much. You took a lot of pain. Yeah, Divya, thank you so much for asking a question. Go ahead.
Hello, sir. That was a very fantastic talk, sir. It was quite elaborative, like how sir said. I have a doubt, sir. Like in myeloma or plasma cell leukemia, usually when we have to differentiate between a primary plasma cell leukemia and a secondary plasma cell leukemia, other than that it has not come from previously treated myeloma, is there any difference in NGS that could help us in identifying if the patient is presenting to us with plasma cell leukemia?
So that's a great question, Dr. Divya. NGS will not help us to distinguish between plasma cell leukemia and multiple myeloma because NGS ultimately looks at the genomic profile of the disease. There is some data to show that gene expression profiling in myeloma does help to distinguish subgroups. But as far as plasma cell leukemia is concerned, there was a very interesting paper from Mayo which was published recently, where they looked at peripheral blood flow cytometry as a marker to identify plasma cell leukemia. And what they found out is, as per standard definition of more than 5% plasma cells in the peripheral blood, which is the standard IMWJ approved definition for plasma cell leukemia, our conventional tests like a peripheral smear examination miss many plasma cell leukemia patients because of problems in identifying the clone. So when they actually looked at combination of peripheral blood flow cytometry with a peripheral smear examination, the pickup rates for plasma cell leukemia were much higher because flow cytometry was able to pick up plasma cell clones which would look normal on a routine examination. And this was long lasting implications because once patients have a primary plasma cell leukemia, they are treated very differently. The initial treatment is aggressive, post transplant consolidation, and we would err on the side of caution and give them slightly more aggressive maintenance strategies. So, I think a peripheral blood flow, if we can do for our patients with standardized techniques, probably we may be picking up more plasma cell leukemia patients. Now, as far as secondary plasma cell leukemia is concerned, this challenge does not come up that often because by the time a myeloma progresses, a relapsed myeloma progresses to a secondary plasma cell leukemia, it's usually a very aggressive disease. And no matter what treatment we give, be it CAR T, be it bispecifics, the outcomes are dismal. But I think we require better techniques to identify primary plasma cell leukemia so that we can treat them more aggressively.
Thank you, sir. But there is no any mutational profile that could differ, right? Like in primary plasma cell leukemia, when compared to myeloma, maybe we can find TP53 or all those mutations. Similarly, is there any difference in primary and secondary?
Actually, I do not know. There may be, but this is something which even I have to look up. Is there any particular difference in the mutational profile in primary versus secondary? I'm not sure.
Sure. Another doubt is like in usually the challenge we have with NGS and myeloma, the thing is we will have to do some enrichment because the clonal plasma cells may be less. And by the time we diagnosed myeloma, the sample that we had kept for flow would be like 1 or 2 days. By then we will have a flow report that it is a myeloma. So will it affect because we know the plasma cells are quite degenerative in nature, and then we will have to send the sample for fish for myeloma. By the time it will be like 1 or 2 days. So is there anything that we could do, like circulating DNA or something like peripheral sample, because we don't have that much of plasma cells usually in the periphery?
Absolutely. I mean, that's a right thing that you pointed out. As far as plasma cells are concerned, the analysis should be done quickly. If we keep it for 48 to 72 hours and then try to analyze it, it will be difficult. So there are techniques like circulating tumor DNA, mass spec to identify these things, but it is still not standardized and available for widespread use. So in our practice, we actually do not wait for flow or any other report. We collect the sample and morphologically we feel it's a multiple myeloma, we run the NGS. And the other caveat is, be it myeloma fish, be it NGS, we always do it on enriched plasma cells. And we have seen when we do it on unselected plasma cells, we tend to pick up a lot of mutations, especially because these patients are elderly. These mutations may be CHIP, or these mutations may be unrelated to the disease process that we are looking at. So it is important to do these tests on enriched plasma cells. I'm not aware of the exact technical details. I'm not a subject expert in this field. But what I do know from my molecular hematology colleagues is, one is there is a certain sense of urgency in processing the samples quickly. And two, enriched plasma cells should be used, be it for myeloma fish or NGS.
Thank you, sir. Thank you so much.
I want to just say something about the first question of yours. With the quality and the types of tests become available, your definitions change.
Mm.
Nowadays, we would diagnose a myeloma bone disease by X-ray, then MRI, then PET scan, and then types of PET scan. Now, plasma cell leukemia, we used to argue about the percentage of plasma cells in the peripheral blood by morphology. And today, you're doing it by flow cytometry, and even a case where there's not a single plasma cell, by morphology, your flow will tell you that yes, it is present and this particular patient has a poor prognosis. So it has become a prognostic marker even for a case whom otherwise you would not have even dreamt of the using the word plasma cell leukemia. So these terminologies of various types, plasma cell leukemia and all, are devised by us, and they undergo change as the time passes. Plasmacytoma, and today we talk about plasmacytoma plus syndrome. Somebody who's got a little M-band, or somebody who's got a little bit of abnormality of free light chain ratio. Uh, say one day free light chain ratio test didn't exist. So we used to talk about non-secretory myeloma. Today, all that has gone because majority of the patient you can document something here and there by either M-band or serum free light chain or by spectrophotometry. So the more sensitive the test, the more you pick up that the disease is different from the other patient. And then your everything changes. The prognosis changes, the approach changes, the follow-up changes, the treatment changes. So yeah, I wish I was 30 years younger. I would have practiced all this that Nikhil has spoken in my life.
Very well
Thank you,
put.
sir. Thank you so much.
Um, there's only a comment by another friend. A very excellent lecture, even though these diagnostic tools are much far for us at the moment. Yeah, I understand. Depends upon where you are placed.
The
Some
same applies to us. Like, despite 90% of what we spoke today is actually affordable only for maybe 10 to 15% of the patients. So there is definitely a need to get these tests. And I'm very sure that's happening. Even within my short span of 7 years in hematology, I've seen the cost of NGS coming down from 20, 25,000 to 10, 12,000. And it is definitely going to come down further. But like you mentioned, sir, the key thing is quality control. With cost cutting, quality control should not suffer.
absolutely. I mean, as a clinician, whatever you ask for, you should also know where to get this done from and insist on your patient to do it from there. Uh, it's so important because you are going to practice based on what data that lab generates for you. If they go wrong, you go wrong.
Absolutely.
I mean, same thing in simple things in past, like a sonography or a echo or a CT or MRI. If the guy reporting that goes wrong, then you go wrong.
True.
So it's so important that you do it only if you have a lab access whom you can trust and where quality is maintained. Everybody can go wrong. And that happens. But that percentage of going wrong should be in a acceptable range. Then it is fantastic. I remember about 10, 15 years ago, guys coming to me that in acute myeloid leukemia, you've got so many drugs, I can give you the sensitivity of the blast to a particular drug in my lab. Now, should from tomorrow I start sending the sample to that lab and they guiding me which drug to use and which drug not to use? I didn't do that till today. And the other day, I transferred a patient of relapsed T cell lymphoma to Singapore. And the first thing they said is that we are going to do the drug sensitivity test to know now what more can I do for this patient. Because that patient had exhausted all the standard protocols, standard treatment, transplants done, and now he is relapsed. But they could trust their lab that the sensitivity given to them will give an extension of life to this guy. So these are our problem as a clinician in our country. We can't trust a platelet count. There are problems that you have to redo it. So
Absolutely.
very difficult days when the quality control is not monitored in this country. Very difficult, extremely difficult. And as I said, community hematologists are 90%. Institutional hematologists are 10%. So where will it go? And the patient moves from the community hematologist of a small rural place finally comes and lands up with Nikhil in his institute and brings all that material which he doesn't want to be repeated.
True. Absolutely, sir.
Okay, I think that's it. So thank you and goodbye. Goodbye to everybody. We have vote of thanks from Adley. Prashant, you're there? Prashant Agarwal, are you there? Okay, so if he is also not there, then I will do the vote of thanks to the speaker, to our chief guest, to all of our audience, and to our event management team. Thank you. Bye bye. Good day.
Thank you so much for this wonderful opportunity, sir. And I would like to thank the event management team and Kalpesh in particular, be it the webinars, any help required, even for live sessions, online, offline. He's always there at any time of the day. So, wonderful event management team. And as always, I thank the MSG for this opportunity and looking forward to more collaborations in the future. Thank you so much, sir.
Most welcome, and thanks for doing this for us. Bye bye.